Well, this is our fourth module in victimology. It's going to be looking at the consequences of victimology. My name is Harry Morgan, and this is a course that is brought to you by the International Association of Trauma Professionals. And again, I think you'll find this to be a very interesting presentation on the consequences. What we'll be covering is the following issues, and that is, first of all, looking at the legal consequences, physical, financial, negative social, and psychological, and finally, the mental health issues and interventions. And so I, again, think that this will be a real practical and helpful course. When we look at the legal consequences, what we see is a couple of terms I think that would be very helpful is to understand restorative justice, and that's a systematic, formal, legal response to criminal victimization that emphasizes the healing of the injuries that resulted from the crime and affected the victims, the offenders, and their communities. So it's looking at the healing of the injuries. And then secondly, a departure from the traditional retributive type of dealing with criminals, retribution, and getting back at, which only tends to perpetuate the conflict. And we've seen that many times. In any time that there is an incident, there is a victim, a suspect, so the victim is going to be first interviewed by the police or a detective, and they're going to be requested a victim impact statement. It can be an oral statement or it can be written, and it's a part of the judicial legal process, and it determines a lot of things later on, everything from the actual criminality to the sentencing of their attacker. Calculations are made of the socioeconomic and psychological loss of the victim, and then there is looking at that as a very substantive part of the whole criminal justice system proceedings. So the victim impact statement is very important, and if you're involved in any way with the victim, you'll be asking if that has already taken place. Victim rights. The privileges and procedures required by law which guarantee victims specific considerations and treatment by the criminal justice system, the government, and the community at large. So this gives a guidance to the victim and to those associated with the victims that they can expect that certain things should be followed. And then the accused, as we look at the judicial system, is often the favored child. They're the ones that everyone is paying attention to. Many make sure their rights aren't violated in the course of the proceedings. And then as a result, there are special laws that exist for the victim's rights, and it's important if you're in any way involved in this process that you know what those rights are. The victim offender mediation, this is where there is a possible face-to-face meeting. There is a mediator that is not only trained but qualified and accepted by the court that permits the victim and his or her offender to meet together and to attempt to resolve the problem. It's also called a victim offender dialogue, or a victim offender conferencing, or a victim offender reconciliation, or restorative justice. A formal judicial procedure is called restitution, and it's used by a judge after guilt is determined as a part of the sentence, in which there can be money or services provided to the victim for the damages or suffering that resulted as a consequence of their victimization. It's to be paid or performed by the offender directly. And there is a potential surcharge that can be added to that for the benefit of the victim. A compensation is a formal administrative procedure, and it's very, very different. And this is where there's money provided to the victims out-of-pocket real expenses that they may have accrued as a result of the victimization, and they're compensated for that. So that if they lost work, for instance, that would be a way in which they would be compensated. And they are being paid then not by their attacker or by the perpetrator, but instead by the state. And they get that money from the Victim Support Fund. When we look at this statistic, it's found in USA Today, but it's actually quoting part of the legacy definition for the FBI. And we're looking at violent crime here, and we see that violent crime has been quite a bit on the reduction. You'll notice it's 1.6 to 1.3, and it's gone down. It was even much below that. It was around 1.2. And since 2014, it's been on the rise, and that's a concern. Now, there are four general types of injuries that the victim sustains in the commissioning of a crime. First of all, there's the immediate injury, and that's where we find if there's domestic battery, for instance, the officer will want to see if there's bruises, cuts, contusions, anything like that. And there are other injuries, however, that are physical that don't leave scars. So it could be that the person, let's say, received a neck injury or a back injury, or where there was a needle that was maybe injected, and they didn't know that there was HIV associated with the needle. So that is the immediate injury. And then there are injuries that leave visible scars, and this is sustained injuries, such as the facial scars and the loss of mobility, things like that. However, it can be much more than that. It could be an actress who, as a consequence of the injury, now they've maybe been disfigured, and perhaps sufficiently that they have no longer a career. So it can be much larger. And then there's the unknown long-term physical injuries, and they can lead to a complete change of lifestyle and even death. So again, there could be the exposure to HIV, or there could be the exposure to something else, hepatitis or something, as a result of a sexual assault. And then there's long-term catastrophic injuries, and these are injuries that restrict the individual's physical mobility. And they could be all kinds of things, such as the victim of drunk driving. You can see how that would cause potential catastrophic injury. And then there's medical aspects that are related to physical consequences, and that is a victim service provider. This is the first responder, needs to have a basic understanding of the types of injuries that a victim sustains. Even though they're not physicians, they need to understand that. And some of the more severe injuries include gunshot wounds, stab wounds, head injuries, and other medical concerns. And then they're the ones that are showing up, they need to be aware of that, because if they're not, they could add a collateral injury to the victim. Then there's financial consequences. The financial consequences can be also very devastating to the victim. 12% of total mental health cost is spent on crime victims. So when we look at mental health, that has in itself, just caring for the mental health can be 12% of the costs that are made. Tangible losses, we're looking at personal crime costs to taxpayers, businesses, and victims, is approximately $115 billion a year. That's incredible. And then there's an estimated 450 billion a year that is to be factored in when we're considering pain and suffering and reduction of quality of life. And then for violent crime, it accounts for $426 billion of the total 24 billion for property crime. So there's an awful lot of, we're talking large figures that are as a result of the victim's cost to the victim, to the insurance companies, to the community, to the taxpayer. It has a rippling effect. Now, there are tangible and intangible losses. The tangible losses are out-of-pocket expenses such as medical care and property loss. So if a person is a victim of a car accident, for instance, they may need to, even before the insurance gets involved, they may need to have now some costs that themselves they would have to pay, or maybe the person that hit them didn't have any kind of insurance, and now the victim is the one that's got to come up with the money to pay for their operations or hospitalization. And then there's the reduced productivity because of the victimization. Now they perhaps are in the hospital. They've lost work, and they if they're self-employed, it's even worse yet. But they now are unable to compensate for the money that they would have normally earned if they were keeping their job. There's non-monetary loss such as pain and suffering and the quality of life, maybe the ability to perform as they had prior to the injury and their victimization. They're the tangible losses. We look now at the intangible losses, and obviously fatal injuries. There's no monetary value we can put on that. But there is a monetary value that's placed on how much people typically spend to reduce the risk of their death. So it may be everything from security, alarm systems, to cameras, lighting, and firearms and other ways in which they're trying to protect themselves. And this could be, again, another way in which there's a financial consequence. There's the non-fatal injuries, especially by the analysis of jury outcomes for pain, suffering, fear, and the loss of the quality of life. So that an individual may have injuries and may have losses, and then they experience pain and suffering, which really finances don't begin to compensate for that. Then there's the negative social consequences. Of course, the first that happens with victimization is isolation. There is a fear, perhaps, of the community or of what the individual is going through, or they're in the hospital, or they're not able to work and have the normal socialization. There's the invalidation of their efforts in coming to terms with their experiences. So they now are having difficulty because of PTSD or other reasons in coping with what had happened. Maybe their inability to respond as they think they should have. There's the withdrawal from family and friends that, interestingly, even though the victim may not have been the cause, now there are people that want to back away and they don't want to spend be close to that individual, especially, let's say, if they had contracted some kind of communicable disease, or if there is HIV involved. It certainly could be resulting in a withdrawal of family. The minimization of the event by others. They're saying, oh, that's not a big deal, or, yeah, I was in a car accident too, or, yeah, well, I was on the battlefield, and yeah, I fought. And so that's the person that is the victim. It's their victimization. And while others may have had similar, it is traumatic for them. And everybody goes through their own trauma in a very unique way. And then there's the loss of support when the victim doesn't return to their old self quickly, because people after a week Well, they say, well, yeah, give Joe a little more time, but if it's after a month, a year, and they say, well, what's taking him so long? Well, he should have snapped out of it by now. And we often see that with vets. They came back from a battlefield. Those back stateside, they didn't experience the horrors of the battlefield, and we wonder what happened and why can't he be the way he was before he left. And so, not snapping back. Eric Lindemann is considered to be a leading pioneer in the study of the effects of crisis on mental health or emotional well-being. There's many definitions for crisis, but I like his really the best. And it says that a crisis is defined as a specified set of temporary circumstances that results in a state of upset and disequilibrium characterized by an individual's inability to cope with a particular situation using customary methods of problem solving. I like that. And victim recovery is then, as we're looking at it, the resumption of the individual to the same or better level of functionality as was enjoyed prior to their victimization. So as we're looking then at the consequences, we're also looking at mental health issues and what does recovery really look like. And this is what we're talking about, the same as or a better level of functionality. And when we look at victim services, we're looking at those activities which are applied in response to the victimization with the intention of relieving suffering and facilitating recovery. And these services include all of those that you see on the bullets there: providing protection, providing information and resources, including counseling, providing financial assessments and compensation, if at all possible, conducting individual coping interventions, engaging in social advocacy, proposing public policy, and working in program development. All of these things are all involved in victim services. So it may be not just the immediate victim, but it would extend beyond that to all of the associations that victim has. The victim's needs analysis, that's one of the first things that needs to be done in terms of helping the recovery of the victim, and that is the identification of physical, social, and psychological needs based on the empirical analysis. What are those needs? And they have to be specified, not generalities. The victim needs to their needs vary in view of the social settings and the nature of each victimization. Each is unique. We can't take one and just homogenize it to all of the others. And then there's an identification of secondary victims, not only the victim that was immediately assaulted or affected by the attacker or by the injury, but also those that are perhaps related, those that are co-workers, those that are fellow combatants, those that are in any way associated with the one who is immediately affected would be the secondary victim. That also needs to be identified. And then we have what we call psychosocial coping. This is a concept that was first introduced by Don Dusic. And he, by the way, is a well-known scholar on victimology. You will find in your Dropbox an article that was written by him that is a summation of victimology. It goes from the definition of terms all the way through to the international concerns. It's a very brief, succinct, but cogent and comprehensive, if you can imagine that, within 5-6 pages. Really a great document. He's considered to be an international scholar. And so he's the one that talks about psychosocial coping. we're looking at more than just the individual, but the entire environment, so that the rate of recovery increases with available resources to the victim. Obviously, the more resources the victim has, the more likely and the faster often the victim will recover. Resources are psychosocial, and they have to be associations, linkages, opportunities that are available to them. It may be the support of the family. It may be the counseling that is available, mental and medical health that is available. Socially marginalized victims have obviously less opportunity to recover. The crisis intervention is the provision of emergency psychological and possibly psychiatric care to traumatized victims, so as to help them return to the adaptive level of functioning and to prevent or mitigate the negative impact of psychological trauma. So that's what crisis intervention is. It's either to prevent or to lessen negative impact and to treat the victimized individual. It has to be planned, forethought. There is usually a team, and they must be professional. They must have been trained in this field and are quite capable of carrying out their responsibilities. The victim trauma includes the emotional and physical experiences that produce pain and injury. So it's not just simply psychological, it's dealing with the whole person. It is also a normal response to the abnormal, to be traumatized, and it's a response to a traumatic event. And it results from the merging of a painful or frightening emotional experience with a specific memory, which, if left untreated, may have a lasting negative impact on the victim's life. So being traumatized is, in effect, a normal response to the abnormal. If a person goes, let's say, into combat and they are not affected by it, we would wonder why, because the individual experienced some perhaps horrific experiences, and a healthy person who witnesses an abnormally painful, violent experience will have some kind of reaction. The more direct the exposure to the traumatic event, the higher the risk for emotional harm and prolonged negative effects. So you can think, if you were in California when 9/11 occurred, obviously it's going to be traumatic to you if you watched it on TV. However, let's say you lived in New Jersey and you were just across the Hudson River from New York, or you were in Bayonne, or let's say you were in Manhattan. Let's say you were right there on the Avenue of Americas. Let's say you were right there where the World Trade Center is. That the closer an individual is to the actual trauma, the greater the effects are going to be of the trauma, and therefore the long-term effects. Other immediate mental health treatment issues include the invent of containment and safety, the assessment of the client event characteristics, addressing diversity in the counseling alliance, acute syndrome reduction, and to assess the post-traumatic stress disorder and identity recovery and reformation. Well, this is going to be actually the balance, or quite a bit of the balance of this module is going to be kind of fleshing this outline out. So first of all, the event containment and safety, the first thing that needs to be done is that there needs to be an assessment of the risk. Is it continuing for the victim? Is the victim aware of their perpetrator? Does the perpetrator know the assailant or the one who is abused? Do they know the place of residence? So if it's a spouse, for instance, do they know where the one they have battered do they know where they are now? Do they know the workplace or the school where this person has been going, or the place of worship or public hangouts? How much does the assailant or the perpetrator know? And also, does the perpetrator have a means of communicating with the victim, whether by phone, email, or direct contact? And then, as we look further, has the perpetrator been identified? Is the perpetrator incarcerated? If they're detained, then that reduces the amount of immediate threats and anxiety. However, there's still going to be a high degree of anxiety. And is there more than one perpetrator? Is it a gang? Is it a group? And next, is the event ongoing or recurring? Is this a one-time event, or is this part of a series? Is there a serial killer, or if there is, in fact, part of an ongoing revenge? Has the victim filed a report or a complaint? So that's why that victim report was important to look at earlier. And that would be a question that would be asked. Was any report filed? And who was it given to? Was it given to the police? And has the victim's daily routine or lifestyle been modified? Are they now afraid to go to work the same way that they went the last time? Are they still using the subway if they're in a city? Are they concerned about walking the dog the same route at the same time? Now, when we look at the client event characteristics, we're looking at the analysis of the event, the legal criteria, the traumatic triggers. We look at determining the client's history of traumatic events, assessing the client's in-group identity attitudes, define the history of the in-group contact experiences. But we also want to look at the pre and post-event psychological symptoms. For instance, did the person have depression prior to the event and now it's been exacerbated? Was there substance abuse before the time of the victimization and now it has been increased? So it's important to assess the client as much as possible in the context of the event. And then we want to look at some core tasks of the clinician, and that is that the clinician's determination of cultural competence and credibility. If the person, let's say, is working with a victim of a sexual orientation that has been, he has been or she has been victimized as a consequence, is the clinician competent? Are they trained to work with transgendered people, perhaps? And are they? Is there a credibility? Is there also a willingness to treat that person with dignity and respect? And then we need to address the clinician and the client counseling if there's any damaging attitudes or behaviors between the two. And if so, then that needs to terminate and refer to someone that is qualified and doesn't have those problems or issues. And then to assess the role of the worldviews in the counseling process. Is there an agreement? If it was, say, a person that had Muslim beliefs and the clinician, let's say, is not of a Muslim worldview, or the individual is from a Middle Eastern country, and the person that is counseling is from a Western nation, would that be in any way a detriment to the counseling process? And then to articulate themes in the in-group resilience and coping, and looking in group, is there an ability to make connections? Oftentimes when working with PTSD or working with people that have been traumatized, especially if there's been a group of people traumatized in the same way, group therapy can be tremendously helpful. So what are the themes, and is that individual able to work through those and be determined to work through those in group? The consequences to responders and to victims, the thematic incident stress. the traumatic incident stress. It occurs in first responders, and that is that if a person is a paramedic and a person is a fireman or a police officer, I was just learning that the police officers that were at the Pulse in Orlando after more than 50 were killed, the police officers who were there that were identifying the bodies and casing the facility, they notified other police officers that they didn't need to come in, that in fact it was wiser that they were the ones that had already been psychologically affected, and in fact now many of them have had to retire because of that. So there is oftentimes for the first responder, and it's not just being untrained volunteers, it can be trained people. If the incident is horrific enough and is in such large preponderance that it can cause the first responder to be traumatized. And so in helping others, it's important to understand the effects of the traumatic incident. And then the individuals may experience physical and cognitive, emotional, behavioral symptoms, or any combination of these, that the stress, the PTSD, is going to be all-encompassing, or may be all-encompassing. There is the acute stress disorder that's the immediate, that's why it's acute, and it is immediately after the traumatic event. Oftentimes there is a tremendous response of panic, high anxiety. There may be the individual that at the time in which the event occurs seems to be okay, that they are numbed apparently, and then after the event they then fall apart. So we're looking at the immediate response to the trauma. Post-traumatic stress is when there has been the development of the characteristics following a psychologically distressing event, and then it's 6 months after the event. It's not that at the time of the event. And victims should avoid stimuli that are associated with the event that results in increased agitation, and that victims of any crime can experience PTSD, or to any traumatic event. It doesn't have to be a crime, it can be an automobile accident. Now, long-term crisis reaction is different from PTSD. This is a condition that occurs when the victims do not suffer from PTSD, but they re-experience the feelings of the crisis reaction when certain events trigger the recollection of the trauma in their lives, such as it could be let's say it's Thanksgiving and their mother was murdered on Thanksgiving. Now every time Thanksgiving rolls around, it's associated with family, it's associated with mom preparing the meal, and now mom's not there, and it just further increases the trauma because now Thanksgiving has been bonded with and associated with the death of their mom. A crisis reaction is processed in 3 stages. The first is the impact stage, and the impact stage occurs immediately after the crime, and it's marked by episodes of mood swings, disordered sleeping, eating that may be disrupted also. So the disordered sleeping can be, by the way, a sleep deprivation, or it can be oversleeping. It can be seen with irritability. It can be seen with just a lot of differing ways, but a marked change in affect that happens immediately after the time of the victimization. There's the recoil stage, and this is the victim attempts to accept or to adapt to the crime and begin to reintegrate their personalities. And so the victim is beginning the process feelings of the crime. Immediately, as we see oftentimes in the stages of death and dying, the first is a response of shock and denial, and then it goes from that to anger. And so the victim may be feeling the same, where initially there is denial, there's a sense of minimization, a sense of shock, and then it goes to anger and then other things. A reorganization stage is when the victim moves toward a more balanced state of rage and fear, that the fear diminishes and the anger increases. So as one increases, the other diminishes. Victims gradually commit their energy to daily life and to more productive ways of managing their victimization. Acute syndrome reduction is now what we want to see is how do we bring, if we have acute stress, how do we deal with that? And that is the goal of this phase of treatment, is the establishment of effective somatic desensitization skills to trauma triggers and to the initiation of a cognitive restructuring of affects and intrusive thoughts that are associated with victimization and outcome contact experiences. Let me just unpack that sentence because maybe not everybody is aware of some of those terms. Somatic has to do with behavioral or body-related issues. Desensitization is that the body is not going to react. So when it sees something that there isn't going to be, or hears something or smells something, is not going to react in such a way that it's going to be reactive, and now they're paralyzed. But to be able to normalize those smells and those hearings and those things, and then the triggers are those, whether it is a smell or a date or a particular location or a name, to be able to reduce the effects of those triggers. And then the cognitive restructuring is a way of rethinking about reframing the thoughts of the traumatization. And the affects, or of course the emotion and the intrusive thoughts, are those thoughts that come in unwelcomed and uninvited. And all of those are associated with the victimization. The acute syndrome reduction also it is including the following: an established treatment goals and options, and that is done with the victim. Skills training and stress inoculation, so it's helping the victim to be able to manage acute stress, anxiety, panic, exposure to desensitization in vivo, which means in life, in context, in the event of the critical event, and then to reframe trauma-induced ideation and attributions, to be able to connect in such a way that they're normalized. And then the skills training for anger and affect management, because as we said, initially it may be numb, but soon the victim is going to express anger. If they are, let's say not everybody will, but it is most common that will be the reaction. And then to measure and educate the victim about PTS syndromes and symptoms of intrusion, of arousal, of avoidance, and so that they are aware that the reason why they have those thoughts just pop in and they may perseverate about them is that's a normal response to a traumatic event. If there is an arousal where they find themselves hyperventilating in response to just hearing a name, all of those things are quite familiar, and thereby it's important to measure as well as to educate the victim to those things. To enlarge a dialogic problem confrontation, so that there needs to be a way of working through, and I'll explain the dialogic in just a little while here. And then monitors symptom change And so if there's a change of sleep, a change of eating, a change of maybe psoriasis, it can be all kinds of things. There may be an increase of anything that is stress related. And the dialogic, as I was just talking about, dialogic recovery, writing about the recall of the events and having a person do that is a way of projecting and getting it out. No longer is it internal, it's now external. We can talk about it. Identifying the traumatic triggers and having the victim themselves do that. Journal writing about the reactions, what they're thinking, how they're thinking about it. Are they now afraid to go to places that before they enjoyed going to? Practices of staying safe. What is it that they're doing to protect themselves, and perceptions that they have of the offender, and what do they now think? Is the offender bigger than life? Identifying the stuck points and the restructuring of beliefs and action, and belief and consequences, being able to identify where am I stuck, and what is the belief that's associated with that point in which I'm stuck. Why is it I can't get past that? What's the thinking that's related to it? The psychophysiological issues, anytime that there is a chronic stress, there is going to be an increased level of cortisol. And as a result, we're going to see one of two things. One is the short term, and I shouldn't say one of two things, it could be both. And that is the short term impact can be sleep deprivation, or it can be having cognitive deficiencies. They seem to have difficulty recalling, whereas that wasn't a problem before. But they find that they now are having difficulty focusing and concentrating. Long term is the hypercortisolemia. The hypothesis, and that is that the hypothesis is that there is an overproduction of cortisol, which is, again, a hypothesis because we don't know for sure with this particular victim if that is the long-term case. So it can have a real deleterious effect on the victim. And then there's SSRIs may be very valuable, which is when we're dealing with PTSD and those who have been affected by trauma, we have found that there are certain things that don't work and certain things that are very effective. For instance, we know that psychoanalytic counseling is of very little value when working with PTSD. And yet we find that SSRIs may reduce the acute rumination, the perseveration, and may enhance intrusive recall of trauma. So that's important. The central nervous system depressants that a victim oftentimes is tending to use, like alcohol, marijuana, and benzodiazepines, they may be abused. So if an individual uses Oxycontin because of being a painkiller, and now they've also found that it helps them to numb psychologically, that can easily be abused by the victim. Somatic desensitization treatments can reduce sympathetic nervous system responses and increase parasympathetic nervous response to traumatic triggers. The sympathetic is the reaction, the autonomic system, the automatic part of the body's nervous system, is that it's going to be reactive, and it's going to put the body on alert. And so that's the sympathetic. The parasympathetic does the opposite. It calms the nervous system. So what is important is to desensitize, to normalize the traumatic events that are associated, the triggers, so that there can be a more normalization in the way in which the brain is processing. Now, your discussion question for this module is, should offenders who have had a history of victimization be treated differently by the legal system than individuals who did not have a history of victimization, and why? Should offenders who have had a history of victimization be treated differently by the legal system than individuals who did not have a history of victimization, and why? Let me explain why I've asked that question. Is that I work an awful lot with those who have been uh, maybe accused of, or maybe have been found guilty of a sexual crime. And I have found that it's not infrequent that an individual that has committed a sexual crime has themselves been sexually victimized. So that's the reason for the question. Should they be treated differently? Well, that's the end of our consequences of victimology. We'll look the next time we're together at the typologies of victimology. I hope you're enjoying this course and getting a lot out of it. I'll look forward to your responses this week.